Good morning, and again, many thanks, Rich, for inviting me today. And I'm going to tell you a little bit about the programme that I've been running for a number of years, and how we need to drive elective surgery as day case, and I think it will become the new normal. And it's the role of what I call GIRFT, which is the Getting It Right First Time programme that I've been running since 2012. Next slide, please. So I'm a frontline orthopaedic surgeon. I have a chair at UCL. But I've been in the front line. I've been a consultant now for 29 years. And in orthopedics, I could see at the Royal National Orthopaedic Hospital where I worked in 2010, from the patients that were referred in, that we needed to do things differently. And with a grant from the government, we used the GIRFT programme to introduce a clinically led, data-driven review of orthopedic services using 12 different sets of data. And this slide shows the impact and results from the orthopedic pilot. Not only has it improved the outcomes for patients, it's used a very much better use of the resource. We've reduced unwarranted variation, and as a result, you will increase productivity and increase efficiency by making those changes that we've driven. And from that, the GIRFT programme developed into 44 specialty work streams. We got a grant from the government of £60 million, and we cover now almost all of the medical and surgical specialties. Next slide, please. Part of that was to look at day case surgery, and everybody will know the BADS directive procedures. It's been around for quite a long time. There have been a number of versions of it, and this is just a table here of the day case rate in an absolute live trust. And you can see what we look is the percentage of index procedures planned and delivered as day case. And this trust is at 70%, where the England average was 52%. The index of day case procedures converting to inpatients, 18%. And then index procedures with 1 day length of stay or greater than 1 length of stay. And you can see this trust on the whole is doing extremely well. So, but unfortunately, if you look then at the England average, there is huge variation. Next slide. Now, when you do a day case, it's all right doing a day case and getting patients out on the day of their operation. But what you want to make sure is that you're not readmitting those patients within 30 days with a complication. Because if you are, then you are defeating the total object of what you're trying to do of providing day case surgery. So this graph again is of a real life anonymized trust. The horizontal black lines show the national average. Below the line is their day case rates for a number of what we consider day case procedures, and above the line is their 30-day readmission rate of those patients. And what you want to make sure is that you're doing high volumes of day case patients, but you have a very low readmission rate at 30 days. So you're not pushing patients out too early, you're not rushing, and the patients are getting the outcome that you want to see. Next slide, please. Next slide, thank you. And then, of course, along came COVID. And what happened in England was that we stopped elective surgery, and around the regions it was similar, although we kept the urgent cancer work going and the urgent sort of surgery that we needed to carry on, including the emergency surgery workload. And you can see as a result of that, the rise in 52-week waiters on the graph on the right has increased significantly in that time. And if you use London as an example, we had 441 52-week waiters at the end of January, 26,000 at the end of August, beginning of September. And not only do we therefore have a large number of patients on the waiting list, we've also got an estimated hidden backlog of between possibly 4 to 5 million unreferred patients because they didn't go anywhere near a doctor or a hospital during the COVID lockdown. So getting back to business as usual is not going to be the answer. We're going to have to do business as usual and probably about another 40 to 50% to get back on track. Next slide, please. So in London, I was asked to lead the transformation of the clinical transformation of the surgical services. And what we have in England, as you'll know, is there'll be 5 regions. And London is a region on its own. And within each region, we have what's called an ICS or an SDP, integrated care system. And what that means is that it's across each of the 5 ICSs in London, that includes a number of hospitals. And what we wanted to focus was was at system level and looking at the population. And the one thing we wanted to drive was equity of access. So the whole system took on the issue of 52-week waiters. And what we also wanted to do was to have excellent clinical outcomes for the population. So I hate the word average, and we want to get rid of that word going forward. And so what we decided for the 6 surgical specialties we've initially chosen is we were going to drive for the top decile of the GIRFT performance, because we've carried out GIRFT visits in all the surgical specialties. We've published 10 national reports on the surgical specialties. We've got another 6 in the pipeline, which were due to come out, but delayed due COVID. And there'll be another 28 national reports published by July of next year. And what we wanted to do with put the top decile was then putting gateways in place for each specialty, so that each ICS signed up to that and how they were going to get to that top decile performance. And from that, we wanted to improve year on year. We also wanted, for the first time in the history of the NHS, I wanted to standardise level clinical pathways across all the providers in London. Never been possible in the history of the NHS, not only in London, but across the country. And so we set up expert advisory panels supported by the professional societies. We also have now given theatre principles about what we expect it to happen in our acute trusts in terms of theatre lists, in terms of productivity. For instance, 10 cataracts on a half-day list, at least 4 joint replacements on an all-day list. And requirements to do that is 2 things. One is you need clinical leadership, and the other thing is you need really good data, which we've developed with Model Hospital, now with the GIRFT data forming the Model Health System, which is actually going to transform the NHS, as I see it, not only in London, but around the country. And we chose the top 6 high volume, low complexity specialties, and we now have 29 pathways. Next slide, please. So this is a gateway. So this is the orthopedic gateway. You can see where I've put the red rectangle. That is the top decile of performance, not only in productivity efficiency, but also outcomes regarding 1 and 5 year revision rates, readmission rates, infection rates, etc. But you'll see one of them halfway down is that we want orthopedic surgery day case rates at 93%, and the orthopedic surgery conversion from day case to inpatient no more than 1.5%. So that is a significant change, a step change for a significant number of trusts. And you can see on the right, that's an ICS in London that has come back and filled in where it is at the moment. And you can see its day case rate in orthopedics at the moment is only 72%, and the conversion rate is 5%. So they have some way to go to make sure they hit the top decile. And we will have 10 of these gateways complete by the end of November, another 2 end of December, and another 2 in January 2021. Next slide, please. So this is the remarkable thing that can happen with COVID. So you can see the 6 specialties. We've started with orthopedics and spines, urology and ophthalmology, then ENT, and then general surgery and gynecology. And you can see the pathways that we have developed within each of those, right from primary care, right through to pre-assessment, bring them into hospital, operations, discharge and follow-up. And these 29 pathways were completed within 5 weeks. Now, if you'd said to me pre-COVID, how long would it take me to get that sorted out? I'd still be struggling at 5 years, I would suggest. But COVID has given us the real impetus to drive change. And these have now been signed off by the colleges, the specialist societies, and will be adopted and will go nationwide. And this is these pathways, 85% of them should be day case. Okay, next slide. So we published this document, which I would encourage everybody to download and get, which is about day case delivery. It can be safe and efficient, and it should be the default position, especially in these times of COVID. We want patients to be treated in COVID-free institutions. We want them as day case because it's resilient and patients feel it's safe and it will maximise our outcomes. And you can see this National Day Surgery Delivery Pack with the Centre of Preoperative Care, defines its staff and leadership, the learning from successful units, day case for surgery facilities, using IT and metrics, the hospital surge escalation with COVID and emergency ambulatory surgery. Next slide. Now, what is going to drive it is data. So I've always been involved and I love data, and we're now getting data that is actually going to transform the service. So this is now from the model health system, which is a conjunction of model hospital and the GIRFT data set. So this is, each of those bars is an ICS or an SDP throughout the country, okay? And what I've just highlighted there is the Southwest ICSs in that Southwest region. And this is the percentage of day cases to all elective activity. And you can see across the country, across the ICSs, there is significant variation. And where we want everybody to be is at the green bar, which is the top decile. So we know that there is a way to go. Next slide. And then you can drill down behind that to look at individual specialty groups and individual operations. So this is a day case for a simple cataract surgery. Again, that is each ICS across the country. This data is about 4 weeks behind real time. So it now gives us a real opportunity to drive change. And if you look at the Southwest region, which I've highlighted there across each of the ICSs for the Southwest region, look at Cornwall and Isle of Scilly's on the right-hand side, which are 97%, but then look at Gloucester at 70.3%. And we want everybody to be at the top decile as the beginning, but Dorset and Cornwall are way beyond that. But now we can use the data to ask the question on why other centres are not achieving in that region what Cornwall and the Isle of Scilly are. Next one. And then you can see the variation between an ICS, which is a group of hospitals. So again, we're sticking to the Southwest. So here we've got one of the ICSs, the Devon ICS, and you can see now we've got 4 hospitals there, and this is day case rates, and each of those bars is an individual trust in the NHS, and you can see that Devon in particular has an issue with day case rates of cataracts, and North Devon in particular needs to look at its service and see what it can do to move the dial to the right to hit the top decile. Next one. And you can look at other specialties too. This is day case rates for TURBT, which is bladder resection, bladder tumor resections. And you can see again, this is the Southeast region. And you can see within that South region, there's Hampshire and the Isle of Wight, which is one of the ICSs. And on the left is Surrey. And look at what Hampshire and the Isle of Wight are achieving in terms of day case rates. But then you go to Surrey with exactly the same region. Why on earth is it down there only 2 or 3% when we want at least 30%? So the data is now very granular. It's very current, will be 2 to 3 weeks behind real time, and we will be able to see and assess and drive change because we've got the clinical community behind it, and actually we now got the data which will show change in real time. Next slide, please. So why do we want to achieve 85% day case rates for elective surgery? So it's safe for patients, it's resilient. We want to produce the top decile outcome, which produce better outcomes for patients, keeping them out of hospital and keeping them at home. We want to maintain the elective care, and part of doing that is to highlight and maximise the day case rate. So what do we need to do that? We've got the leadership, the GIRFT programme. I lead the whole programme. I've got clinical leads for every specialty, and we've got leads who are respected and appointed by the specialist societies and also the colleges. The data, the model hospital, the model health system is absolutely going to be critical to this. And we've also had great anaesthetic support. So we've now got an agreement from anaesthetists in London that we will no longer have an anaesthetist in a theatre on patients who are having a cataract operation. We've agreed now it'll all be topical anaesthesia for at least about 98% of those patients. We've got operational support in London. Everybody's behind this, and we've got top-down cover from the regional director, Sir David Sloman, and the regional medical director. And clearly, we want to make sure that we work very closely with the integrated care systems to actually drive the change. And with that combination, and with COVID, we can now drive change now, which we could never do before, and we can embed those changes. Thank you very much.
Tim, thank you very much indeed. Sort of a huge amount of insight packed into a short amount of time. If we could all show our sort of virtual appreciation for Tim. Thank you very much indeed, Tim.
Yes.
There's a applause echoing around rooms across the country. Tim, thank you. We're going to have time for questions in just a moment, but I think Kieran, we're going to hear from you next. Kieran.
Yeah, thanks, Rich. I'm going to be really brief, actually, and I'm going to talk about 3 areas where I think using day surgery is a great way of trying to understand how large-scale change happens or doesn't happen in the NHS. I said in my initial comments that this is a story that's gone on for something like 3 decades, back to the formation of the British Association of Day Surgery, which is, I think, around 1990. The early work by the Audit Commission, sadly no longer with us, in the 1990s. And then subsequently a bunch of work by a whole host of different agencies. We all remember the Modernisation Agency, don't we? We remember the Productive Ward Programme, NICE, and GIRFT follows in that tradition. So I'm going to talk about 3 areas where I think the story helps us to understand large-scale change: leadership, finances, and data. And then I want to say something briefly about the content and the implementation of day surgery. On the first, leadership, Tim follows in a really interesting tradition of powerful clinical leaders. I listen to Tim and I think of David Dunn, who 30 years ago pioneered getting general surgeons to collect their own data and share it. I think of Brendan Devlin, who set up the National Confidential Inquiry into Perioperative Deaths and made himself quite unpopular, actually, I think, with some of his colleagues in pioneering that work on confidential inquiries. I think Ben Bridgewater and his work around cardiac surgery outcomes and getting cardiac surgeons to collect and share their outcome data, and therefore leading to significant changes in practice. And Tim follows in that tradition. So this kind of change has required some quite extraordinary clinical leaders, but also a kind of institutional leadership. So if you look back over those 30 years, we now have some embedded systems for institutional leadership in areas like this, through organizations like NICE, through investments like GIRFT, that we didn't have in the past. It relied much more on those, if you like, solo champions. Second thing I wanted to mention is money. So over this period, I think at different times, money has been both a barrier and an enabler to taking forward day surgery. But the tariff systems which have been used have in part, I think, been really important enablers in creating situations in which organizations who adopted day surgery, who acquired the best practice tariff that was associated with it, were then able to use those resources to invest in other ways. It's a really important lesson, because we're at the moment, we're heading towards block contracts again in the NHS. And I think there are some really important lessons for us about not losing the value of financial incentives, but also not believing it's just about financial incentives. The third point, which actually Tim made in spades, is the power of data, the power of comparative data, and what it means when you sit with hospital leaders, with senior clinicians and others, and they see those comparative charts and they see their own position on those charts. What I think we've also got, we've got far better data than we had 30 years ago. We're also much better at drilling down and using that data, not just to show comparisons, but to try and understand the reasons for those variations. And that's something that, Tim, you might want to come back on discussion on trying to understand, why is Surrey so different from somewhere else in the same ICS. The fourth and final point I wanted to make was about the kind of content of the change that day surgery involves, because it's not just, this is not my expertise, but I think it's worth saying it's not just about obviously changing to day surgery. It's about changing anaesthetic practice. It's about changing the organization of services to split elective and emergency services. It's about staff scheduling, but it's also about staff expertise in day surgery. It is an organizational bundle of change, which is actually really hard to implement if you're an individual enthusiast. You have to have a sense of collective purpose in the organization, and you have to have the will of the organization and its leadership behind that change being introduced. It's also not a change that is easy to trial. And one of the things we should think about is how we persuade people this is the right thing to do, if it's not something they can easily simply try out. But they have to invest in the idea and put a lot of effort into changing systems and processes. So I'm going to stop at that point, Richard, because I'm kind of conscious of time. But I think there's a huge amount to learn from day surgery. On the one hand, I could say we've come an incredibly long way in 3 decades. On the other hand, we could all say why has it taken 3 decades to achieve the kind of change? And there are some echoes in what Tim has had to say that you would find if you went back and read the Audit Commission's work in the 1990s. And I think there's a truth in both of those. So I'll hand back to you, Tim.